Okay, I want to just, since I left off here, um, this area of withholding food, um, normally what happens in a clinic, let me get my chat back up here. Okay, normally there's going to be a little, I'm not saying controversy. Doctors feel differently. Normally our receptionist would call all patients the night before to remind them they have surgery the next day and to remind them about fasting. Sometimes they have the technician do that. If it was a special case, the receptionist could maybe call all the routine spays, neuters, dentals. But if I had a cat, there was a special case. If I had an exotic or a dog, then usually the technician would give specific instructions for fasting for what we, want to do. Again, there was a good question asked yesterday. Um, some of our pre-meds, and when we go over drugs, ace-promazine has antiemetic properties. It is a sedative. That's the main reason I'm giving ACE, but it does sometimes prevent some nausea. Now, if you have a dog coming and vomiting, we don't give ace-promazine, okay, because it's a sedative primarily. But if I give it in part of my sedation protocol, I may get the benefit um, to prevent some vomiting. Now that we have Cerenia, and Cerenia is so widely used, a lot of pre-op protocols, every dog gets a shot of Cerenia before surgery. It's kind of become a routine medication that we give. So you do have that option. The patients that I don't like fasting, the exotics, neonates, pediatrics, and potentially some geriatrics. Um, Again, like normally what I'll say is we don't withhold them overnight, but we maybe don't have them eat in the morning. So it may be the night before everything's normal, and in the morning you withhold breakfast. And I never withhold, most patients, we didn't withhold water at all. They could have water up until the time they leave the house. So I just wanted to reiterate that. And the big reason that we fast them, the reason that we're fasting them is so they don't vomit during anesthesia. That's our goal, is we don't want regurgitation and vomiting, because anesthesia, you have relaxed airways. Anesthesia diminishes reflexes, and so you're supposed to have a protective reflex. If there's vomiting, you have a higher risk that they're going to potentially aspirate stomach contents, regurgitated fluid into their lungs. Now, it is ideal for every patient receiving anesthesia to have an IV catheter. Now, if we just sedate a dog for x-rays, or if we sedate a dog for a nail trim or a grooming, we're not necessarily placing an IV. So this is usually if it's going to be a lengthier procedure. I will tell you, I have sedated bulldogs for things, and I like to put a catheter in bulldogs, even if it's sedation, because if they crash, if things don't go well, I want to have emergency access. So the primary reason I want you to know we place IV catheters is to give fluids during anesthesia, to give IV fluids, and to have rapid IV access. When I started off in practice in Chicago, I would take my needle with my barbiturate, that's what we used, and I would tape the needle into the leg with the syringe. We didn't place IV catheters. But, that needle can move around. It wasn't exactly stable. So an IV catheter is the gold standard, being that you can do this. The other thing is you can give constant rate infusions. That is a lot more popular now. Even when I was at Purdue, we weren't doing a lot of CRIs, but that was, a long time ago. Now there's a lot of different constant rate infusions. Morphine, we do something called an MLK drip. An MLK drip is morphine, lidocaine, ketamine. You add morphine, lidocaine, and ketamine to a liter of fluids, and we run those fluids throughout the anesthesia. It provides some sedation and analgesia, and I can run lower anesthetic gas to my patient because I'm giving them a constant intravenous administration of pain medication. Fentanyl, a fentanyl CRI. Now, fentanyl is hard to get right now because of abuse and human medicine, but fentanyl has to be given IV, and you can give a fentanyl. It's great for pain. So if you have a very painful procedure, it's going to be ideal. Sequential administration of incompatible drugs. What that means, sometimes we give a patient Valium, and you might want to give it propofol, or you might want to give it Valium and then, a little bit of morphine. Valium is not compatible with other agents, okay? Valium will cause this precipitate. So if I have a catheter, I can give the Valium, I can flush, and then I can give another drug. So sometimes drugs will interact, and you can't mix them in the same syringe. So it's better if you have a catheter, because I can then just hook up one syringe, give the drug, hook up the next syringe, and give the drug. And we always say, choose the largest bore or the largest size. Cats, we usually use a 22 gauge catheter, but if I've got a Maine Coon or a really big cat, I've put in 20 gauge IV catheters in cats. I've seen big dogs have a 22 gauge catheter. I mean, at minimum, that dog needs to have a 20 or an 18 gauge catheter. And in Great Danes, like if we have a GDV, sometimes I've put in bilateral 16 gauge catheters. 16 gauge is, the lower on the number, the bigger the size, okay? So 16 gauge, and a lot of you guys that are into piercings probably understand gauge is better because of piercings. It's not necessarily catheters. But when you go into those bigger gauges, and the reason being is I know in a GDV, I may have to push fluids very quickly in an emergency. And, if I'm trying to push drugs through or push fluids through a small catheter, it's going to be more difficult. So you always want to go for the biggest size you can. We always say, don't be wimpy. Now, I'm not really getting into catheter. Like, hopefully you guys have already talked about this in your injections or catheter class or Tech 3. Is that when you guys do catheters, I think? And you guys already have done this. Saline flush, you got to have all that set up. Now, let's get into why they need fluids during anesthesia. Now, even a normal patient that's healthy, you should get IV fluids during anesthesia. It's going to give them basic support. Now, if we have, again, you did this in Tech 4. Miranda, I said Valium is incompatible with other drugs. You can't mix Valium. The only thing you can mix Valium with in the same syringe is ketamine. If you put Valium with another drug in a syringe, it creates a precipitate. It looks like a snow globe. So any patient, if they're dehydrated, if they're anorexic, or they have disease, they're going to deplete something called ECF. ECF is extracellular fluid. Does anybody need me to print that off or write that out? I'll just do it just in case. Holy mother, okay. Okay, so ECF and ICF. Now you'll see ECF written more. It's extracellular fluid. So that's fluid that lives outside of the cells. And that is in the vessels outside of the blood vessels. There is fluid throughout the body. Any dehydration, anorexia can deplete that, and normally fluids would replenish that. Now, when we give fluids, you want to give fluids that are a similar makeup of body fluid. Okay, we want to try to match the fluid that would be in the body, the pH, the content, and that's why you probably talked about different fluid types. Now, what do we have to deal with in surgery? Obviously, I want to know if they're dehydrated or have a disease. But even if I have a normal patient, there is an anticipation that the patient is going to lose some blood. They're going to have some hemorrhage. perioperative. Now, hemorrhage, you always think, oh my God, blood's everywhere. You know, I mean, there is acceptable blood loss, and then there's going to be blood loss that is more than anticipated. And that fluid is lost from the intravascular space. Okay. If they're bleeding from their vessels out. Now, if I give fluids intravenously, I'm replacing fluid into that vascular space. Normally, those type of fluids have to be similar to ECF. There's a lot of notes under this slide, but there are two types of fluids that we can do. We can get into the colloids and we can get into crystalloids. Crystalloids are always going to be our main category. So let me get into this. But there's a note here about hemorrhage below. You can lose albumin. Albumin is the protein component of the plasma. Albumin is very important for fluid balance, drug binding, basic healing. So if you lose enough albumin, we're going to, you know, and I'm going to talk about, you can't necessarily replace albumin. So we're going to get into what do we do in that case. When we have the hemorrhage, blood, water, electrolytes, if you lose enough blood, occasionally you're going to administer blood products. Now we're talking about, you know, if they were hit by a car and say it damaged the liver bleeds a lot. So if you're going into surgery, you may deal with an animal that has quite a bit of blood loss existing. The only thing is you cannot give blood if you don't know where they're bleeding from. Because if you put it in and it's just pouring out of the liver into the abdomen, that's not helping. Sometimes we got to get into surgery, stop the bleeding, and then we can administer blood so that we're not wasting what we just gave. If you have lost albumin, or say the patient has a low albumin to begin with, this is when we get into plasma and colloids, because blood plasma is going to give our patient, and plasma is a natural colloid. So that is natural. That would have to be, my dog, when I was at Purdue, we could sign our pets up to be donors, and then we get like a free bag of food. So once a month, I took in my Golden at the time, and she was a plasma donor. So she would give her blood, they would spin it, they'd separate off the red cells, and they would just bag up the plasma. And, you know, and so that plasma was stored in the hospital if an animal needed plasma. There's a blood bank at IndyVet, and they have their own blood bank on the south side. Most, like VCA, we ordered blood products from a company. So we ordered them and kept them in the hospital. Plasma is called fresh frozen plasma. I don't know if you've gone into plasma and blood transfusions. I feel like you should have had that in a class by now. Maybe. Okay. So I'm not trying to like reteach you everything, but when we get into plasma transfusions, the reason we do that, the number one reason is our patient is low on protein. So plasma will replenish protein. Plasma also contains clotting factors. So if we have an animal, now not like a Doberman with von Willebrand's, but if we have certain clotting disorders, plasma can be helpful. So it can be for clotting, but most of the time when we get into plasma transfusions, we're talking about the patient has low protein. Okay. And you have to have access, you know, to those products. Not every clinic is going to have access to plasma. We're talking usually about, you know, specialty or referral if you need that. Now, the big thing about IV fluids is fluids typically have electrolytes. And the electrolytes I'm talking about is sodium, potassium, chloride, calcium. Some have lactate. If you're ever bored, well, when you're in a clinic, you can look at a bag of IV fluids, hang on one second, sorry. Sorry, my son was digging out. We had a big, like a dead, like a thin tree stump in the back, and he's been digging it out, and it was very difficult. So I was like, "Did you get it out?" And he did. So the benefits of having a strapping teenage son at home. So sorry, I needed to answer that. But okay, when we give fluids, we are usually replacing something that is similar. So the electrolytes, all of IV fluids, if you look on the front of the bag, will tell you what percentage of those electrolytes. And different IV fluids have different concentrations of those electrolytes in the bag. The other thing that we can add are sometimes buffers. Lactate is a buffer. We can add dextrose. Dextrose is for sugar. So not every fluid bag is going to have a high concentration of dextrose or sugar in it. But the basic way that I divide this out is crystalloid versus colloid. Now, there's a lot of notes underneath that will be helpful. But let me give you an example. Well, crystalloids are your basic fluids. Almost every patient is usually going to go on a base crystalloid. I don't even know what kind we have at school right now. Lactated Ringers is a basic one, Plasma-Lyte, and that is our everyday replacement fluid. Has solutes in it, and solutes are dissolvable products like the electrolytes. May have some dextrose and buffers, but it's giving back the body what is in the basic electrolyte fluid in our body. So it's replacing, so crystalloids. Now, when we get into the types, like there's some here. One thing to add, and hopefully you went over this when you talked about blood. If you were giving a patient one of these crystalloids and you needed to add a blood product, you cannot administer fluids and a blood product in the same catheter. So you would have to put in a separate catheter to give blood. It is not compatible with crystalloid fluids. It can cause lysing or breaking down of the red blood cells if you give it together in the same catheter. We call it piggybacking. So a lot of times a dog has an IV line and we want to give something else, we'll piggyback or put it into, so you'll have two things going into one line. That's okay with a lot of different drugs. It is not compatible with blood products. So if they're getting blood products, plasma, packed reds, whole blood, they need a separate catheter, not their IV fluid catheter. So this is going to give us, they're isotonic. Isotonic is like the fluid that we have in the body. No, Katie, Hedastarch can go in an IV catheter line with fluids. Hedastarch is compatible, and Hedastarch is a synthetic colloid. But thanks for asking that, because yes, I'll get into when I talk about the two different ones. The things that you have to look at. Now, this is what the doctor will do. Like a lot of times in emergency, we'll take in a dog that has vomiting or diarrhea. The dog needs fluid, but the doctor will want to look at the blood work to look at the electrolyte levels and decide which fluid. At VCA, we have 3 of these different types of fluid. And the doctor would like, sometimes they like one. I worked for a criticalist. He did not like lactated ringers because a lot of critical patients had high levels of lactate already. Well, we don't want to give a fluid that contains lactate and then increase that lactate. So he preferred Plasma-Lyte or Normar. So there's little differences in those fluids. And if someone's being very specific, again, he was a criticalist, he was very specific. He says, I don't want to start fluids till I see the blood work. Then he will pick, because some have more potassium, Some have dextrose, some have more or less sodium chloride. So there is a lot that goes into picking the fluids. Now, some basics clinics carry one type of fluid and that's what everything gets. But when you have advanced renal disease, diabetics, Addisonian patients, trauma patients, those electrolyte levels we have to watch, and the fluid choice makes a difference. Okay. Now, let me get to my chart for a second. I'm going to just explain. So, okay. Sorry, that's probably humongous, but you can see this. So up here it says IV fluids. It's, whoops, kind of hidden up there. You have crystalloids and colloids. Every patient basically goes on a crystalloid. Okay. Basic fluid replacement, routine fluids, gives you electrolytes. It gives you vascular support. When you vasodilate a patient during anesthesia, if you give them IV fluids, you boost the vascular volume, you improve blood pressure. One of the first things we do when an animal has crappy blood pressure in anesthesia, besides turning down our anesthetic, is a lot of times we give them a fluid bolus. And we're trying to bolus or increase vascular volume. Now, these are the types of fluids that are most common. And then saline fits in. Now, saline, the basic one that you get on the shelf, is 0.9%. And the main reason that we use saline is to basically, I have on here, flush the IV catheter, bathe the tissues. During surgery, if you're the scrubbed in assistant, you will get a little bowl of saline. And if Dr. Ritz wants you, sometimes you'll dab the tissues with saline. A lot of times during intestinal surgery, one of the jobs of the assistant is to draw up saline and squirt it over, because a lot of times the intestines are pulled out during surgery, they're going to get dry very quickly. So you use saline to moisten the tissues. So saline is typically used, as a solution, and 0.9% is your basic saline. Now, saline, I wrote a little arrow over here, comes in different types. Isotonic saline is 0.9%, but there is hypotonic and hypertonic saline, and you have to look at the percentage on the bag. 0.5% is half the strength of 0.9. It is hypotonic. Now, what that means, that has a different level of sodium. Now, sodium chloride. Sodium, think about this. Sodium is a large molecule. Typically, sodium draws to it, okay? Like if you eat something salty, your lips get, it draws the fluid out of your lips. So if I put sodium in a vessel, what do you think it's going to do from the fluid outside the vessel to the fluid inside I just put I put sodium in a vessel. And I'm fluid hanging out here. What is this fluid going to do? It's going to be drawn to it. Okay. Yeah. Now, it can. Now, Michaela, what it normally, it's going to draw from the outside space inside. If it pulls it out of a cell would shrink. But we know extracellular fluid is hanging outside the vessel. It's going to pull it in. It's also going to help you keep the fluid that is in the vessel in there. Now, hypotonic is going to allow fluid to escape. We don't use hypotonic a lot, but if we have an animal that has fluid overload or got too much fluids, if we give hypotonic saline, it's going to get rid of some of that fluid. It's not going to hold it in the vascular space. Now, the one you may run into down here is hypertonic. Hypertonic comes in different strengths, 3, 5, 7%. I think it even goes up to 24%. The most common I've seen in clinics is the 7%. Hypertonic has a very high level of sodium in the fluids, and it will act in an emergency situation. If you have a dog crashing and they need fluid quick, Like they need to boost their vascular volume. If you give hypertonic saline, it's going to draw all the fluid from the extracellular space in. And it's quickly, you're going to boost your blood volume. But what's it going to do to the tissues outside of the vessels? It can cause dehydration. So if you pull too much fluid from the extracellular space into the vessel, then you could potentially dehydrate the tissues. So when you use hypertonic saline, you have to make sure your patient has adequate hydration level to begin with, or you have to give, sometimes the doctor will give LRS and hypertonic saline. They're going to give base fluid, they're going to add hypertonic saline to give an extra boost. It works very quickly in an emergency to boost blood pressure. It doesn't last long. When you stop giving it, that fluid's going to go back out and your blood volume's going to go down again, or your blood pressure. So hypertonic saline is used quickly in an emergency. So hopefully everybody understands this. These are the basic fluids right here you're going to use all the time. This, the problem with saline as an IV fluid, saline is literally sodium and chloride and water. It does not contain potassium, calcium, lactate. It doesn't have a lot of electrolytes. So that's why saline isn't used like as an IV fluid for everyday patients, because it's not replacing all the electrolytes we need to replace. So saline is usually used, you can give it with blood products. It won't interact. So you can flush a catheter and you can run saline into those fluids with the blood. Because a little tip, when you have a blood transfusion, you have a bag of blood and you have a line. When the bag is empty, you have a long line that's still filled with blood. Well, nobody wants to waste that blood. I will put a little port and I will inject saline into the bag of blood to run all the rest of that blood to the patient. Because I'm not throwing out an IV line worth of blood. But I can add saline to that bag and kind of like rinse all that blood out and make sure that patient gets every red blood cell. You can do that with saline. You cannot do that with other fluids. Now, if you look at this other side of the chart, colloids have your high molecular weight. They are about the size of a protein molecule, okay? So protein will keep fluid in the blood vessel, all right? If I have low protein, those animals typically have leaky vessels, or what happens is they give up their fluid from the vessel and they give it outside. So if I give them a colloid, I'm helping replace that molecular weight and it'll help hold fluid in. So colloids will pull fluid into the blood vessels. And if you think about it here, it increases oncotic pressure, it increases vascular volume. That's why you use colloids. Now, the two forms of colloids are natural and synthetic. Blood has a high molecular weight. Plasma has a high molecular weight. Those are both colloids, but they come from a natural source. They come from a blood donor. And when an animal, like I just explained, donates blood, they're either a whole blood donor, packed reds, or plasma. Animals that get whole blood transfusions get all of the fluid, the cells, everything. Animals that get packed red blood cells are just getting red blood cells. And then animals that get plasma transfusions are just getting the plasma or the water component. But I've already explained why would an animal get a plasma transfusion. So natural colloids are here. Synthetic colloids, and like Katie had asked a question about this, synthetic would be Vetastarch, het starch, and oxyglobin. And there may be a newer one now. These are the ones that were the most common. The thing that I want you to know, you never, ever, ever just give a colloid. An animal is never on a drip of Hetastarch by itself. You are usually giving them LRS, Plasmolite, Normar, and then you're adding Hetastarch to maintain that fluid in the space. See, if I'm giving a dog electrolytes and they don't have a lot of protein, okay, if I give them vet starch, that molecule is going to help keep my fluid in the vessel. And then the more fluid I keep in the vessel, I improve my blood pressure. So remember when I said if I have an animal with crappy blood pressure, I can give them a fluid bolus. If I'm really concerned, I will sometimes give a vet starch bolus, and that will even help more by holding it in. So if an animal has a low protein, they can be given vet starch or Hetastarch. You're not replacing protein, but you're replacing something that's about the size of a protein. It's going to act like a protein, okay? It may not help with drugs, with protein-bound drugs, but when we give colloids, we are worried about vascular support. Hopefully you went over this when you talked about fluids. Let me mention one thing about oxyglobin, because if you've never heard of this, it's bovine synthesized hemoglobin. It is by nature a synthetic colloid. It came from bovine hemoglobin, but it's been added to a synthetic molecule. So it is considered synthetic, not natural. If you have an animal that has a low hemoglobin, say from anemia or blood loss, and you don't have access to blood products, oxyglobin looked like a blood transfusion bag. And the big thing you worry about in low hemoglobin is your animal doesn't have enough oxygen carrying capacity. So by giving oxyglobin, oxygen now has something to bind to. The nice little side effect of oxyglobin, it is a colloid. So oxyglobin, the reason I'm giving it is for oxygen support, hemoglobin replacement. The nice little effect is it's a large molecule. It can improve blood pressure, and it can help keep fluids in. But the main reason, so oxyglobin isn't really given for blood pressure. It's not given because we're worried about fluids. You give oxyglobin when you want to replace hemoglobin, but it is considered a colloid fluid because of its molecular size. Okay, did that make sense? Hopefully it's designed to be helpful. Okay. And again, a lot of this should be review. All right, let me get back to my screen. So, and the other reason I make a note to make sure you guys understand saline, sometimes a company will send you the wrong saline, or like at BCA, we have all the saline bags on a shelf. If the doctor says, I want a bag of saline, and you grab the 7% saline instead of the 0.9, that is not for every patient. And actually can cause some dehydration. So you got to be careful with your salines. Normally hypertonic, we're giving it because of shock. And when an animal presents in shock, they're vasodilated, they have really low blood pressure, high heart rate. And what hypertonic saline does very fast is it's going to suck extracellular fluid or fluid that's outside the vessels. It's going to pull it into the vessels, and you're going to get this very fast boost and an increase in blood pressure. So we only do it in acute emergencies when we need a really fast boost of pressure. But when you stop giving it, the effects go away very quickly. When you give Hetastarch or vet starch, those effects for fluid support stick around longer. But the nice thing is if you have acute hypovolemia, hypertonic saline is going to be your best. Now, this is something to understand. Every clinic that I've worked at always has a bag of dextrose fluids in the closet. And then the doctor comes to me and he goes, I want you to make up a 5% dextrose solution for this patient. And I'm always like, well, there's a bag in the closet that says 5%. It's already made. The problem is dextrose solutions that you buy are dextrose in water. So it's literally sugar and water, no electrolytes. There's no, so that's why most doctors, we usually buy concentrated dextrose, 50%, it comes in a bottle. And then if we have a puppy that's hypoglycemic, the doctor will say, I want like a 2.5 or a 5% solution. And then you will add dextrose to the IV fluid bag, because then your patient is getting electrolytes and dextrose. If you use dextrose in water, it's literally sugar and water. You're not replacing anything. So normally these bags of fluids like just sit there. I would say in my career, I don't think I've ever used a pre-prepared bag of dextrose. I've always had to make it for every patient. So that's why we teach you how to do solutions and dilutions, because there are times in your job where you're going to have to make up a special bag of fluids for a patient. So I've already talked about the colloids. It breaks it down into, the big thing is colloids have a high molecular weight, and they give us blood volume and they improve blood pressure. But you never give a colloid without a concurrent crystalloid. Okay, I've maybe said that 2 or 3 times now. Because what's going to happen if you give hetastarch by itself, it's going to pull fluid from outside the vessels, and it can cause dehydration. It's going to pull fluid towards it, especially if you have a patient that already has a level of dehydration. So colloids or hetastarch is a supportive fluid. And I talked about hemoglobin, oxygen carriers, oxyglobin. The blood is natural products, natural colloids, and then there's synthetic. Now, some caution about fluids. You always have to worry about giving too much. The big things we worry about when you give too much fluids is pulmonary edema or cerebral edema. And so you have to watch that fluid rate very closely, because those are the 2 tissues where extra fluid tends to gravitate, but that's the 2 areas where we're going to potentially, if you have too much fluid in the lungs, they can't breathe. If you have too much swelling on the brain, it's going to affect your CNS reflexes and function. Some things to look for if you're giving too much fluids: if you have any ocular or nasal discharge, drip, 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 drip during surgery or post-op. Now, I've had dogs have a runny nose. A lot of times I wipe it with a little tissue, and I'm like, okay, that discharge looks just like fluid, and sometimes that happens. But you would also see some of these other signs. Chemosis. Chemosis is swelling of the eyelids. Now, if you've seen those pictures of those cute puppies that get like stung by a bee, and they got the really swollen face, but imagine if the eyes were puffy and they kind of rolled in, or if you pull down here and the conjunctiva is swollen. Sometimes chemosis is going to be really a swelling of that conjunctiva, but it can make the eyelids look swollen. Increased lung sounds, harsh lung sounds, dyspnea or increased respiratory rate, potentially hemodilution. If you do a PCV, it may actually drop your PCV because you're over diluting the vessel. I had a sad case of this when I was at Purdue. We had an ophthalmology department, and we had surgeries all going on at the same time. So I'm in my surgery suite doing my surgery, and I have the ophtho-techs come out. They've got a puppy in surgery, and they're like, our fluid pump keeps beeping. Beep, beep, beep. We can't figure out what's wrong with these fluids. Now, this is an OR. It's dark. They've got drapes over this dog, and I kind of look at the pump, and I'm looking at the dog, and All of a sudden I look at the fluid bag. Okay, it's a liter bag and it says it has 400 mils left. This dog's been in surgery an hour and a half. And I look at the bag and I look at the tech and I said, was this a new bag of fluids? Now this was about a 20, 25 pound puppy. And they said, yeah, that was a new bag. And I go, there's only 400 mils left. This means your dog got 600 mils of fluids in an hour and a half, a 20, 25 pound dog. We turn on the lights, we undrape, the dog's eyes are completely swollen shut. The face is a little swollen. There is fluid coming out of the nose. The lungs are harsh. The dog goes into cardiac arrest, passes away. Can't get oxygen. We look at the fluid pump, and at Purdue, the fluid pump, you hook up the fluids and you had to dial in the fluid rate. And the dial was these little, you had 3 boxes because you could go up to 999 mils an hour. But you had to go through every number all the way to 9 to get back to 0. The dog was supposed to be getting 20 mils an hour. Somebody didn't zero out the 100 space and they left the 9. This dog was getting 920 mils an hour. And hopefully that horrifies everybody. It was a mistake. It's a medical mistake. Mistakes happen. What was happening, the pump was beeping because you have a puppy with a 22 gauge catheter and you're telling the IV pump to pump 920 mils an hour and the pump is going beep, beep, beep. You know, there's too much pressure. And the problem is a lot of times, and I've been guilty of it, is you have a pump beeping, you just keep hitting start. But you know, sometimes the dog is sleeping and their leg is like this, or the line is under their elbow. And these fluid pumps are trying to push, and if they get resistance, the pump beeps. Now, personally, it was a mistake that they did. And it was, you know, we all talked about it. And, you know, there was some yelling on their part. I mean, I wasn't part of their department. I was just trying to help them fix the problem. But, you know, things needed to be double and triple checked. But the puppy had all of these, the ocular, the nasal discharge, the chemosis, which is the swelling of that conjunctiva. And then when you listen to the lungs, they were extremely harsh. It was just too late to try to give Lasix and to try to give fluid, to try to pull all that excess fluid off this dog. It was just too much. So whenever you're giving fluids, the other thing that a safety tip, when I have a very small patient, a pediatric patient, our clinic had 250 ml bags and 500 ml bags. I would not put a giant bag on a little patient because if somebody sets it wrong, okay, it's going to deliver that. If I have a little bag of fluids and I realize in an hour the pump tells me I'm out, I'm like, well, wait a minute, 250 mils at 20 mils an hour should last you this many hours, if that makes sense. You guys will work with fluid pumps, and you have to be careful. And the other thing I do is I set how many fluids to be delivered in an hour. And I will set a very low amount on pediatric patients. So it will warn me if it runs out too quick. So those are just little tips that, yes, Michaela, if they would have investigated sooner, yes. And I think they just kept looking at the line and they kept thinking, you know, it was a puppy, so short legs. You know, they kept trying to pull the leg and say, maybe it's kinked. Sometimes you think the catheter is up against the vessel. I've been in ICU some nights where I've got a beeping pump all night. It's driving me crazy. And I'm like, why does it keep beeping? Why does it keep beeping? But the problem is nobody looked up at the bag and looked at the pump and saw that the beeping was because the rate was too high. The pressure was too high, unfortunately. So a lot of things were learned by that case. And, you know, like I said, there's things that you can do with puppies or kittens on fluid pumps to make it safer. And that's what I do. I set low volumes to be delivered. I set a volume to be delivered per hour. So I need to go in there every hour and add another hour's worth of fluids. But if I set something wrong, it's going to beep at me if, so you can set a pump to say deliver 100 mils total volume. At 20 mils an hour, that's 5 hours. The pump will beep. I can set that volume lower so it beeps at me more often, and I check my volume closer. So I do that in the little guys or, frail cats, because you don't want to overload them. Other things that you have to get ready before surgery, obviously you get your fluids ready, you figure out the type of fluid, you'll figure out a rate. When you guys go into surgery rotation, you will get a formula sheet with dosages that'll tell you if it's a cat, you run this much. If it's a dog, you run this much. But we also sometimes will get antibiotics. In Tech 6, you go over this. We don't give antibiotics if you have good sterile technique. You've clipped the patient, you've prepped the patient. If you've done your job, unless they're under for an hour and a half or longer, you don't typically need antibiotics. Okay, so we don't give them to every patient. But if it's a longer procedure, if it's an infected procedure like a PIO, if we're going into a joint, we always give them antibiotics. Preemptive analgesia, when I get into pain, that's stopping the pain before it starts. I think of it this way. What if you knew at 4 o'clock today you were going to have a massive headache, and you could take your Advil at 3:30 or your migraine meds at 3:30, right? But we don't know that. If I'm doing surgery, I know I'm going to cause pain in this animal. Why don't I give them pain meds before I start surgery? And that way, when they wake up, hopefully they wake up without as much pain. There used to be if you work for an older time vet, and sometimes vets haven't kept up on newer things, a lot of people were saying, if they're painful, I'll give them something. Or if they feel pain, they won't move around. Oh, God, don't get me. You get me on Dr. Pole, I'm going to talk for another half an hour. I know some people love him. Maybe he's a great grandpa. He needs to get up on the times. I can't remember, it was your class or somebody's class, was like, he's just such a cute grandpa. And I go, oh, that's great. Maybe he loves his grandkids. He shouldn't be practicing veterinary medicine on small animal patients. What I've seen him do with large animal is pretty appropriate. Yeah, that's great. I'm like, he can be a wonderful, sweet, caring man that you want to hang out and have a cup of tea with. I don't want him operating on my dog. Okay. But there used to be a theory that if a dog felt pain and you just operated on their leg, then they won't move. If they're pain-free, they're going to move too much and hurt themselves. That myth has been debunked, okay? That is not the way to practice veterinary medicine. You need to give the animal pain medication, okay? It's a good sign. If that dog is up wagging his tail and moving around, that's what we want. So, yeah, I mean, one of the reasons Dr. Pole got in trouble, and it was a televised surgery, is he had a dog under anesthesia with no monitoring equipment, no oxygen, no endotracheal tube. He had one drape on the patient. I don't even know if he had gloves on. No cap, no mask. And somebody reported him. All they had to do was watch the episode. And we know that you need to, if you want to watch a vet show, watch those. They're 3 black guys, Sci-Fair Animal Hospital, Vet Life. Love those guys. They practice very good medicine. They practice, right, Bo? Bo, do you agree with me? Say yes, Mom. I agree. I want oxygen and ECG and fluids when I have surgery. Dr. Jeff's not bad. Is that the guy that looks like a biker dude? I like the Exotics show. The guy that looks like the biker dude, they cut a little bit of corners because it's a a cost or low cost. You know who I love is the lady in the mountains. Yukon Vet, whatever her name is, Yukon Vet. She's great. I'd love to work with that lady for a week. Well, maybe not completely in the mountains with some of the things she works on, but that would be cool. Yeah, she's great. Yeah, so Vet Life, the guys that work out down in Georgia or something, all those other shows, the thing with it's that, I'm kind of getting myself on a tangent, but the preemptive analgesia, the idea is to give them pain meds and give them on a regular basis before they show pain. And this way, the animal, you can use much lower dosages. If you have a dog screaming and crying in pain, you have to use a much higher dose to overcome that pain threshold. I will get into this more in depth. I don't know why my dog is freaking out right now, but I will get into this more in depth when we do have a lecture on pain. But that is one thing we do in the pre-op period. You can give antiemetics, anti-inflammatories, antibiotics, because if we start this stuff in the pre-op period before they're anesthetized, they get in the system and they start working. And again, I'll come back to this in a little bit. So there's a lot of notes under a lot of these slides, so there's added stuff there. Do you have any questions regarding what we've talked about today? I know the fluids, I felt like, the thing I want you to understand about fluids is, why do we give them during anesthesia? Which category potentially, would I get? And my big take home message is, you don't give a colloid without a crystalloid. Your crystalloid is your everyday fluid. Your colloids can help boost volume. And that's what I want you to know is, why am I giving this? Why am I giving this? What my plan is I got to look at everybody's homework. So I've been getting them in. Tomorrow, I'd like to go through that homework. It's kind of a review. And then I would like to maybe talk about the case that I sent. It talked about the workup of that Labrador. So we'll go over the study guide, and then we'll plan on the test Friday. Does that make sense? Does anyone have any questions? Okay. Well, if no one has any questions, as long as you've typed here, I think I've seen everybody type here. I will just see you tomorrow. Make sure you have your study guide. I'll get those points entered. We have to run, they're taking, since my son couldn't graduate, he was supposed to graduate this Sunday from Cathedral, they have their cap and gown, and we get to go take pictures on campus. We had to sign up for time slots, so not everybody's on campus. So I have to run to go look better than this and go take some pictures for graduation. So